I think we can start now. It is already 7:35.
Okay, ma'am. Dimple.
Okay, ma'am. Good evening, teachers. Today I'm presenting a case of 42-year-old male farmer from Vellarada, presenting with complaints of redness and pain, diminution of vision, foreign body sensation of right eye since 1 week. History of presenting illness. Middle-aged man was apparently normal 1 week ago when he had injury to right eye by plant stick while working. Few days later, there was onset of pain in the same eye. Pain was sudden in onset, had progressed gradually over a week, which is pricking type. Diminution of vision was acute in onset, rapidly progressed to the present state. Associated foreign body sensation, discharge, redness, and intolerance to light was present. No history of headache or use of glasses. No history of colored halos and diplopia. No history of floaters and glare. No history of topical steroid medications. Past ocular history. He was diagnosed to have diabetic retinopathy changes in both eyes from elsewhere in the past. No history of previous ocular surgeries. Medical history, he is a non-diabetic for past 14 years on oral hypoglycemic agents and was started on insulin since 2 years. No history of systemic hypertension, no history of tuberculosis, asthma, epilepsy, not on any immunosuppressive therapy, no relevant family history. Personal history, mixed diet, appetite is normal, sleep is disturbed, bowel movements regular, bladder habits were normal, no history of smoking and alcoholism. General physical examination, patient was conscious, cooperative, oriented to time, place, and person, was examined in sitting position in daylight with consent. Vitals, pulse rate 70 beats per minute, regular rhythm and volume normal. Blood pressure 130/80 millimeters of mercury from right upper limb in sitting position. Respiratory rate is 12 cycles per minute. He was afebrile. No pallor, icterus, cyanosis, clubbing, lymphadenopathy, no dependent edema. Systemic examination, cardiovascular system, S1, S2 heard no murmur. Respiratory system, normal vesicular breath sounds heard, no added sounds. Per abdomen was soft, non-tender, and no organomegaly. Central nervous system, higher mental functions were normal, no neurological deficit. Ocular examination, head posture was normal, no facial asymmetry, visual axis parallel, extraocular movements of both eye, ductions and versions were full in all directions. Visual acuity right eye, 4/60 with pinhole, no improvement, measured with Snellen's visual acuity chart at 6 meter distance, eyebrows were normal, orbital margins were normal, and there was mild lid edema and discharge present over the eyelashes. In the lacrimal apparatus, puncta well opposed to the ocular surface, lacrimal sac was normal, Roplast test was negative. Conjunctiva, there was diffuse congestion and circumcorneal congestion. Cornea, the size and shape was normal, sensation was intact. As in the figure, 2 grayish-white paracentral oval-shaped infiltrate, each measuring around 2 mm vertically and 3 mm horizontally, with central epithelial defect measuring less than 1 mm was seen. Paracentral area of right cornea at 8 o'clock and 6 o'clock position. And the lesions had feathery margins with dry-looking base. Depth of the infiltrate extended up to anterior stroma with surrounding corneal edema. 2 to 3 smaller white punctate lesions of size less than 1 mm was seen adjacent to this infiltrate with clear cornea in between, suggestive of satellite lesions. Iris color and pattern was normal. Anterior chamber, Van Her grade 4 depth and grade 2 cell reaction was present. Pupil single, circular 3 mm size, central position, reacting to both direct and concentric light reflex. Lens, nuclear sclerosis grade 1. Anterior vitreous cells could not be assessed and IOP could not be checked. Fundus could not be assessed in right eye. Left eye, visual acuity was 3/60 with pinhole, no improvement, measured with Snellen's visual acuity chart at 6 meter distance. Eyebrows and orbital margins were normal. Lid and adnexa position and movement was normal. Skin over the lids was normal. Lid margins were normal. Eyelashes normal. Palpebral fissure width and height was normal. Lacrimal apparatus, puncta was well opposed to ocular surface. Lacrimal sac was normal. Roplast test was negative. Conjunctiva was normal in left eye. Cornea size and shape was normal. Sensations were intact. Iris color and pattern was normal. Anterior chamber, Van Her grade 4 depth, optically clear, no cells or flare. Pupil was single, circular 3 mm size, central position, reacting to both direct and concentric light reflex. Lens, nuclear sclerosis grade 2. Anterior vitreous cells, no cells. Intraocular pressure was 16 mm of mercury with Goldman applanation tonometer. Fundus examination, left eye disc color size shape margin was normal. Cup disc ratio of 0.3:1. Arterial venous ratio of 2/3. Macula, there was dot and blot hemorrhages present. Hard X-rays were noted. Foveal reflex was not seen. Summary. A 48-year-old non-diabetic male with history of injury to right eye with vegetative matter presented with complaints of pain, redness, diminution of vision in right eye since 1 week. On examination, right eye vision was 4/60 with pinhole no improvement. Just paracentral corneal infiltrate with feathery margins and satellite lesions were noted around the infiltrate. And the provisional diagnosis, right eye corneal ulcer, probably mycotic corneal ulcer, nuclear sclerosis grade 1, type 2 diabetes mellitus. Left eye, non-proliferative diabetic retinopathy with clinically significant macular edema and nuclear sclerosis grade 2.
Okay, Dimple, this was a very good presentation, because I say it is a good presentation because most of the PG students for their examination, when they are describing a corneal lesion, they don't make a color-coded diagram or describe it in relation to the limbus according to a corneal clock cover, where it is exactly present in the clock cover, how far it is away from the limbus or pupil. These things are usually overlooked by for their clinical examination during examination. So you have done a very good presentation, but there are some things I want to ask. You said there is the history of diabetic retinopathy. Don't you want to ask something more about the history of diabetic retinopathy? When was he diagnosed to have diabetic retinopathy? Did he take any treatment for that?
No, ma'am.
And was he diagnosed to have
Elsewhere, he was he was diagnosed with diabetic retinopathy changes, but he was not evaluated further.
Did not have any laser.
When he came, he just told me he had some diabetic changes. It was noted from somewhere else.
So that you have to add that to that. Whenever there is a history of diabetic retinopathy, you have to mention whether any treatment has been given or whether treatment has been advised. Maybe
Yes,
sometimes the treatment will be advised, but they will not be able to take it.
Yes, ma'am.
Then family history has said there is no significant family history or related family history, something like that. In a corneal ulcer case, what family history you are expecting?
If, in case of peripheral ulcerative keratitis, autoimmune disorders, collagen muscular disorders are.
But that is not coming in the family history. That does not run in families. Then coming to the pupil, he is on treatment or you are seeing it for the first time?
For the first time, ma'am. For the first time.
He has not
First visit.
taken any treatment so far.
No, ma'am.
That's why I asked about the pupil. You said the pupil is normal size.
Pupil is normal size.
You have given a differential diagnosis of bacterial, acanthamoeba, viral. Why? Oh, no, you have given a provisional diagnosis. Show me the previous slide. Oh, corneal ulcer, probably mycotic. What type of mycotic organism? Probable organism.
Probably in our tropical area, the most common one is Aspergillus.
No, I am not asking from your tropical distribution, from the clinical findings. Is it a yeast or is it a filamentous?
Filamentous fungi, ma'am.
Yes. What is the clinical presentation in if it was a candida, yeast-like fungi?
In candida infection, it will be usually seen in immunocompromised individuals.
The immunocompromisation can be of various types. Local immunocompromisation can also occur. That is not there. What is the clinical finding? If it is a mycotic, it's a candida ulcer.
With creamy white base will be there. It will not be like dry looking ulcer as in case of filamentous fungi.
More clear. It is not at all like a filamentous fungal ulcer like picture. It is more like a bacterial.
Bacterial ulcer, well-defined margins with nectar. Whitish creamy colonies will be there.
Round ulcer with a deep stromal presentation. So we have seen a corneal ulcer in the OPD. How will you proceed to manage it?
Here, clinical findings are matching with the corneal ulcer, fungal corneal ulcer, with the history of trauma with the vegetative matter. And here the patient is having trauma with vegetative matter, and the symptoms are, since 1 week the patient was not coming to the hospital. So the symptoms were mild, and the signs suggestive of feathery margins and the satellite lesions.
It's all
dry looking ulcer.
Diagnosis. but management is a different aspect. So if any corneal ulcer, how will you proceed to manage it? That is my question.
Initially, I would like to do the blood sugar levels to know the control status of the diabetes, if it is there. So, and then if I will look for any foreign bodies is there, so I will remove it, and in a traumatic lashes will remove it, and we'll do the syringing to check for any diagnosis surrounding infections which can cause the corneal ulcer, and will initially then we'll decide on starting the medications. Before that, corneal scraping was done. I would like to do the corneal scraping from the OPD itself.
Going for the corneal scraping, we have to look for some more corneal local risk factors. There is a strong history of injury. You said the duct is free, there is no ROPAS is negative, well, no foreign body. Did you ever delete and look for any foreign body? But the ulcer is more in the lower part, isn't it?
Yes, ma'am.
There is definitely history of trauma, but some other precipitating factors may also be present. What are the other things they especially look for in a corneal ulcer in the lower part?
Traumatic lashes, misdirected lashes.
No, they are all very rarely produce corneal ulcers. More importantly than that.
Entropion.
No, entropion is causing a corneal ulcer by trichiasis.
Trichiasis.
You have to look for any exposure.
Exposure keratosis.
For any facial nerve weakness. Then
Yes, ma'am.
more importantly, is there you said corneal sensation is normal.
Any lag of thalamus?
Yes, lack of thalmus and any neuroparalysis. Yeah, check that corneal sensation. They have to do the corneal sensation in any case of corneal ulcer, because neuroparalysis may be the etiological factor contributing to the infection. Then comes the systemic factors, diabetes and all that. You have to be, and I will take the scraping. Can you hear me? Dimple?
The connectivity issues under seems to be stuck with the connectivity.
I think she has lost connection. Meanwhile, some other PG will be there. Who is the Saina Matthew? She's a PG student.
Jayalakshmi IT ആരാണ് ഒന്ന് മ്യൂട്ട് ചെയ്യാമായിരുന്നു.
She's a president or our Jayalakshmi. Everybody is muted. Elizabeth is muted. Saina Matthew is muted.
ജയലക്ഷ്മി ആയിട്ട് എനിക്ക് അറിയത്തില്ല. ഡിംപിൾ വന്നു. എന്താ ഡിംപിൾ പ്രോബ്ലം അവിടെ? കണക്ഷൻ കിട്ടുന്നില്ല.
നെറ്റ് കണക്ഷൻ പോയതാ മാം.
ആണോ? സാരമില്ല.
You can continue. Did you hear my question? How will you proceed?
കേട്ടില്ലാന്ന് തോന്നുന്നു മാഡം.
You said you will take a culture and sensitivity study. How will you proceed to do it? That is my question.
Sorry, ma'am.
You said you will go in for a culture and scraping for culture. So it's a pathological examination, no? How will you proceed to do it? Can you hear me?
Yes, ma'am. Corneal scraping was taken, and this corneal scraping, the corneal tissue was placed in 2 slides. One for the KOH mount.
Will you take the corneal tissue? That is the question. How will you
Sorry,
take?
ma'am.
How will you take the tissue?
Yes, ma'am. From the slit lamp itself. Hello, ma'am.
Yes.
Some problem with my laptop, ma'am. That's it.
Okay.
I will take the corneal scraping in front of the slit lamp, and we'll put the paraffin points.
How will you take the scraping? That is the most important part. Your histopathological.
Yes, ma'am. Yes, ma'am.
It's all depend on how will you do the scraping. How do you do it?
Yes, ma'am.
How will you
Yes, ma'am.
proceed?
In front of the slit lamp, I will put 0.5% of the proparaquine into patient's eye, which has got a least bactericidal activity. And with the help of Kimura spatula or 26 gauge hypodermic needle
I think yes, she has closed.
Dimple muted ആണ്. Dimple, now you are muted in the laptop.
Hello, ma'am. Am I audible?
Yes.
Yes.
So in front of the slit lamp, I will put the 0.5% of 0.5% of the proparaquine, which has got a least bactericidal activity, into the patient's eye. And after that, with the help of Kimura spatula 26 gauge hypodermic needle, or with the help of Ball Parker 15 blade, or with the help of calcium alginate swab or platinum spatula, will scrape. Before that, we'll remove the necrotic debris from the cornea, and then we'll scrape from the center and from the edges of the ulcer, because streptococcal species will be seen at the edges, and from the center, the moraxilla species will be there. And we'll do the scrapings, and then into two slides, into one which the 10% of KOH, one slide for the KOH stain, and other for the gram stain. For the KOH stain, we'll put this corneal tissue into the center of the slide, and we'll put 10% of KOH into it, then cover with the cover slip. And
I think he has again gone off.
am I audible, ma'am?
Yes.
Yes.
So from the edges and the base, we'll take the corneal tissue and we'll put on the slides, one for the KOH and one for the gram stain. And for the KOH, we'll put 10% of KOH in a drop into it and put the cover slip, and we'll examine under light microscopy, and we'll get the result within 5 minutes. If there is KOH, will loosen the corneal lamellae and will expose the fungal filaments. And also that shows also will destroy the corneal tissue, which shows the fungal filaments in an homogeneous background. And next is we can also do in the presence of gram stain. The gram appear as pink in color because of the presence of thick peptidoglycan cell walls. And the other light microscopic methods include periodic acid shift, lactophenol, cotton blue staining, and
Dimple.
Grocots, gomorin, methenamine staining.
Excuse me, Dimple, this is not a theory exam. This is a clinical discussion. You have to be more on the practical lines. You are describing so many things, so many stains, so that is not the thing. One important thing is you have to take the scraping after removing all the necrotic tissue. That is the thing that I have been waiting for you to say, because that is a very important thing. You will not get the organism if you are scraping off all the slough from the surface. So you have to first of all remove the slough and take from actually
debris, necrotic debris, then take the scrapings
then
from the edges and base.
You don't want to do any culture.
Yes, ma'am. Here we are suspecting the fungal organism, so we can do culture in Seborrheic dextrose agar or potato dextrose agar or a brain heart infusion agar.
You say that
for the culturing of fungal organisms.
medium is used in your hospital. Have you
Sorry,
ever?
ma'am.
Have you ever gone to the microbiology department of your hospital and seen what culture they are using?
Seborrheic dextrose agar.
For fungal. Seborrheic, okay. For bacteria?
Sorry, ma'am. Bacteria blood agar can be used.
Yes. How do you take?
Except for the fastidious organisms, blood agar can be used.
You directly inoculate into this, or you take the thing into the lab scraping?
No, ma'am. Directly inoculate. We'll directly inoculate into it. Otherwise, contamination can occur.
So
into the solid agar.
You and the patient are sitting in front of the slit lamp. So you have all these things with you. That's a cover slides, cover slip, soap rods, and the blood agar. All these things are with you.
No, ma'am, before scraping, we'll collect it from the microbiology department.
No, I collect it. Of course, you have to collect it from the microbiology department. I am asking, as you proceed to do the scraping, you have to collect all the materials from the microbiology department and keep it by your side. So, so that you can do all these things all along.
Yes, ma'am.
That is the process you do in your hospital.
Yes, ma'am.
Yes, that is how you proceed. Okay. Suppose there is no facility for doing this scraping and smear and culture and everything. You are working in a peripheral hospital. You are seeing an ulcer like this. Then how will you proceed?
So clinically, the findings are matching with the fungal corneal also. So we can start on with the topical antifungals.
No, you are wrong. That is what I am waiting for that answer. In no ulcer, you should not start any fungal ulcer, fungal.
Broad spectrum antibiotics can be started immediately.
Pardon?
Broad spectrum antibiotics like fluoroquinolones can be started empirically.
Antifungal, immediate, not antifungal, a broad spectrum bacteria.
Antibiotic.
Why that should be started immediately as soon as you have taken the screen or you have examined the patient and can you hear? Is it difficulty in hearing me? As soon as you have taken the smear or you have clinically examined and ruled out all the local etiological factors, you start on a broad spectrum antibiotic. What else?
Then the clinical findings are with the fungal corneal ulcer. So
no. I am asking. It is. I already said. People may be doing so many things, but the dictum is never start an antifungal straight away. I will tell you why you should not start the antifungal. But you have started a broad spectrum antibacterial. What else you will give? You give only
along with that, other adjunctive therapy with the cycloplegics for the symptomatic relief of the patient. Cycloplegics like atropine, hometropine can be given, and to relieve the ciliary spasm. And
what is the role of the cycloplegic?
Sorry, ma'am.
What is the role of the cycloplegic in a
cycloplegics like 1% of atropine, 1% of atropine or 2% of hometropine can be given to relieve the ciliary spasm to prevent the formation of synecdoche and to increase the anterior UVA blood flow. Thereby more antibodies are entering into the anterior chamber and will react against the pathogens.
No, that is not the answer. Why does cells and flare appear in a corneal ulcer? In any corneal ulcer?
Because of the toxins released by the microorganisms, it may cause iritis or iridocyclitis.
Any corneal ulcer, any serious significant corneal ulcer, you expect an anterior uveitis. To counteract the anterior uveitis, you are giving this
cycloplegics.
Cycloplegic with reatics. You give atropine or hometropine or whatever drug you prefer.
1% of atropine or 2% of hometropine.
Which one you prefer? Or why?
2% of hometropine.
That depends on the type of ulcer. If it is a small ulcer, you expect it to heal in 2 days, you will not give atropine. You have to be subject. Why?
Because of the side effects of atropine and it lasts. The duration of action lasts for...
Not the side effects, the effects of atropine. It's not a side effect, it is the effect. Because a small ulcer may heal in 3 or 4 days, but the effect of the mydriatic and cycloplegic effect of atropine may last for 2 to 3 weeks. So your ulcer has healed, but your patient will be unhappy with your treatment. So in small ulcers, you give hometropine. If it is a large ulcer where your treatment is going to be prolonged for weeks and also the anterior weight is going to be more severe, you have to give atropine. So that depends on the type of corneal ulcer. Then what?
Then to reduce the intraocular pressure, we can give anti-glaucoma medications.
But only if it is intraocular pressure is raised. You don't give anti-glaucoma medications in all cases of corneal ulcer.
No, ma'am. If the intraocular pressure is high,
How will you
if the
measure?
intraocular pressure is high, only we can give anti-glaucoma medications. Otherwise, systemic analgesics can be given to reduce the pain.
You give it topical or systemic anti-glaucoma medications?
Based on the intraocular pressure, topical 0.5% of timolol eye drops can be given, or systemically carbonic anhydrase inhibitors like acetazolamide can be given. 250 milligram 4 times daily, or IV mannitol can be given.
This is all theory.
Based on the
Simple. This is a clinical discussion. So you have to be more practical. How many cases you have seen IV mannitol given in a corneal ulcer? Have you seen
if
any
it is
given IV
if the
mannitol?
pressure is too high, it may cause impending perforation. Then only we can give IV mannitol.
Yes.
If the pressure is less, then we can give topical
Even
medication.
if the pressure is on the higher side, we will give only acetazolamide,
Topical
not mannitol, because this raised intraocular pressure is not going to go away in 6 hours or 10 hours. And also you can expect you need acetazolamide only in cases where there is so much hypopure, or there is already a shallow anterior chamber where the mydriatics are producing an angle block. You expect or suspect an angle block due to the shallow anterior chamber.
Yes, ma'am.
If there's a hypopure, that means these cells and exudates can block the angle. Only then you give acetazolamide. So it is better to avoid topical anti-glaucoma medications in a corneal ulcer, because all these are epitheliotoxic.
Yes,
And if
ma'am.
you have to take so many drugs, means nothing will be taken at the adequate dose. You are giving some antibiotic drops. How frequently you will ask them to apply it? You are giving, you said you will give a broad spectrum antibacterial drug.
Yes, ma'am.
How
Yes,
frequently you will advise the patient to apply it?
Like fluoroquinolones, 0.3 percentage of fluoxetine or 0.3% gatifloxacin or 0.5% moxifloxacin can be given in an hourly manner for 1 to 2 days. Then advice follow-up.
First of all ulcer cases, preferably you have to treat them as IP patients. Or if there is no facility, they should be followed up daily basis. Why?
Yes, ma'am.
Why?
To know to see the improvement, whether it is healing or worsening.
That is the general thing, but the most important thing is, if it is a pseudomonas ulcer, 2 millimeter ulcer you are seeing today will be a near total ulcer in 24 hours. So no ulcer can be taken lightly. All corneal ulcer cases has to be taken as a medical emergency. So you treat it only if you and the patient are there for regular follow-up. Once they start healing, you can decrease the time interval, you can increase the interval between the follow-up days. But if you are starting treatment in a corneal ulcer case today, it is absolutely essential that you see him tomorrow. And here, make sure that the patient is putting the drops correctly and it is responding to treatment. How will you assess the response to treatment?
A symptomatic improvement of the patient, whether symptoms are getting better, and based on the reduction in the signs, like rounding of the ulcer edges.
This is a clinical discussion. Symptomatic are better, signs are better. This is not the answer. What symptom will be better on the next day if the ulcer is healing? What symptom? His vision will improve. His symptom is pain. If the ulcer is healing, the pain will be less. That is the answer.
Vision will improve.
Vision will not improve. In 2 days or 3 days, vision is not going to have much difference. The most important thing is you ask the patient whether he is feeling better. Pain is less. That is the thing in the symptoms. Then signs. What about the signs?
Rounding above the edges, disappearance of feathery margins, and if any satellite lesions were there, it gets disappear. Also, the corneal edema, cornea become clear, And stormal edema gets
All these
reduced.
things
AC
won't
reaction will get.
All these things won't happen in 24 hours. This will take 3 or 4 days at minimum. The next day, the most important thing is the ulcer is not becoming larger or deeper. That is the most important criteria whether it is responding to treatment. Then the surrounding corneal will be clearer. Corneal edema will be less. The edges and rounding off and all these things will take 2 to 3 days. So the next day, what you are expecting is the ulcer is not getting bigger or deeper, and the patient's symptom means pain is less,
Pain.
and the surrounding inflammation is coming down. That is the corneal edema is less. Then why did I say that you should not start antifungal straight away? Any idea?
Antifungals are having corneal toxicity.
Yes, that is one reason, but the most important reason.
Yes. It will not produce immediate results because of a lesser penetration. And
A fungal corneal ulcer will progress very gradually, unlike a bacterial ulcer. So there is no emergency to start an antifungal immediately on seeing it. You start the antibacterial drugs, if it's not showing response and it is worsening, you have to think in terms of it is an antifungal. It's a fungal ulcer. What is the danger if you are starting antifungal, antibacterial, anti-acanthamoeba, all drugs together? Ulcer is proving, but you don't know which drug is causing the response. It may be a bacterial ulcer. You have started a fungal, antifungal. You don't know when to stop it. When will you stop treatment with antifungals with a fungal corneal ulcer?
if the cultures are negative,
No. You are diagnosed a fungal corneal ulcer and you have started antifungals. Ulcer is healing. So when is the end point? When will you stop the treatment?
continue the treatment for about 6 to 8 weeks.
Ulcer is not healing in 6 to 8 weeks. The fungal ulcer may take 2 to 3 months to heal, depending on the size. That is, the weeks or days is not the criteria. Antifungals has to be continued at least 2 weeks after any all apparent healing of the ulcer.
Yes.
Unlike a bacterial ulcer, you can stop the antibacterials once the ulcer is healed, because once the ulcer is healed, that is, you are sure that all the organisms have left the place. But in a fungal ulcer, the epithelium have healed, the opacity has come, but there may be fungi still present at the lesion. And fungi may go into the anterior chamber, unlike a bacteria. So you cannot stop fungal treatment immediately once it is healed. You have to continue it at least for 2 weeks after the all healing has occurred. So why
Yes,
we don't start antifungals? It is of course toxic. You have to make sure that it is a bacteria, at least clinically, that it is a fungal ulcer which is not responding to antibacterial therapy. And also these drugs you have to give for a long time. These are all very toxic. What is the primary drug line of treatment for a fungal ulcer? What drug you will give?
topical 5% of natamycin suspension.
What? How frequently?
Topical 5% of natamycin can be given in an hourly manner for 24 to 48 hours.
Yes, after that.
Ma'am. Then along with the broad spectrum antibiotics can be given. Then if the results were not satisfactory, then we can add other antifungals like 0.5% of amphotericin B, 2% of fluconazole to increase the penetration of the natamycin.
What will you do to increase the penetration of natamycin?
Additional amphotericin B 0.15% or 2% of fluconazole can be added along with natamycin.
Amphotericin is not going to increase the penetration of natamycin. To increase the penetration of natamycin, you have to do the repeated scraping of the because it is a suspension. It will not penetrate deep into the corneal stroma, but it is the broadest spectrum antibacterial, antifungal drug that is effective against many and filamentous fungi. So you have the first line of treatment is of course natamycin. Even many studies have shown that the organazole is not as effective as natamycin. So you have to give natamycin frequently, at least 2 hourly, and alternate day scraping is needed for the ulcer, remove all the slough, and if the epithelium is growing, you have to remove the epithelium and make sure that the drug is reaching the fungi deep inside the cornea.
Yes, ma'am.
What else is available? Amphotericin drops you have to prepare from the IV.
Yes, ma'am.
It's more commonly available antifungal.
And newer antifungals like voriconazole.
What is the role of systemic antifungals?
Systemic antifungals are indicated if the ulcer is deeply penetrating or if sclera is involved, if endophthalmitis is suspecting, then we can give systemic antifungal like imidazole or azole. Triazoles can be given. Imidazoles like ketocon 200 to 400 milligram per day can be given, or ketoconazole or as triazoles can be given, like fluconazole or itraconazole can be given.
You can give ketoconazole or more effectively organazole can be given. Systemic
200 milligram.
Systemic medicines are indicated more in bacterial or fungal ulcers, and why?
More in fungal ulcers, because fungal ulcers are deeply penetrating.
Deeply penetrating means bacteria can also deeply penetrate and produce a perforation of the cornea. Why it is indicated more in a fungal ulcer? Because a fungal ulcer can extend into the sclera, and also if a bacteria will not penetrate an intact Descemet's membrane, but a fungus can go through the intact Descemet's membrane and reach the inside of the eye. So systemic, in a very large fungal ulcer, systemic antifungals are also indicated. Suppose it is not healing, what is the next step?
If it is not healing, then local causes has to be ruled out.
Local causes have to be ruled out at the very beginning, not when it is not healing. Of course, when it is not healing, you can reevaluate your local causes. But how will you manage the ulcer, a non-healing fungal ulcer?
If it is not responding to that particular antibiotic, we can rescrape and send for the culture and sensitivity. And if as it is not healing, we can change the antibiotic based on the culture and sensitivity.
Discussing a fungal ulcer. In fungal ulcers, we are not going to get any sensitivity reports. You have done a scraping and confirmed it is a fungal ulcer. You have given all the treatment. It is not responding. Many cases will not respond due to various reasons. Maybe the patient is not putting the antifungals properly, or it is some.
We can do corneal biopsies. Corneal biopsies can be done to debulk the infection and thereby to increase the penetration.
Fungal infections, you are not going to get any sensitivity reports, culture and sensitivity reports. Corneal biopsy is done in ulcers where you are not able to identify the pathogen by your scraping. That is the area where a corneal biopsy is indicated to find out the pathogen. Here you have seen that you have identified a pathogen. It is a fungus, a filamentous fungus. You have started all antifungals. It's not responding to treatment. Maybe it is too deep, too extensive, and it is the antifungals are not reaching enough, or it is patient is not non-compliant and is not putting the drops properly, or the organism is not responding to that particular antifungal you are putting. So what is the next step?
Whether any other factors like exposure is there, we have to supportive measures has to be taken. Surgically,
That is one thing. You have to reevaluate.
therapeutic keratoplasty can be done.
Factors. That is okay. But the treatment factor, that is the step.
If the medical therapy is not, if the ulcer is progressing, then we can do the therapeutic keratoplasty.
That is not as simple as that. There are certain other steps you can try. Can you give an intrastromal injection of voriconazole?
Yes, ma'am. Intrastromally, intrastromal voriconazole or amphotericin can be given. Or intracameral voriconazole about 5 micrograms per 0.0 ml can be given, or amphotericin 5 to 7.5 micrograms per 0.0 ml can be given around the ulcer at multiple sites.
Yes. Why the therapeutic keratoplasty is the last option? What is
Because we are doing it for the therapeutic purpose and not for the visual rehabilitation.
not a therapeutic keratoplasty? What is the prognosis in therapeutic keratoplasty in a fungal ulcer?
It can result in a recurrence of the ulcer.
Why?
Recurrence due to persistent epithelial defect or suture-induced related problems, and post-operatively we are not putting steroids.
Not a recurring suture-related problems is not the cause. The fungal will remain in the even the normal
Recurrence.
Normal cornea surrounding the graft.
Yes,
On the base, where ideally it should be a lamellar keratoplasty. Because if a Descemet's membrane is penetrated, the fungi will go inside. So the fungi can retain in the normal cornea and produce a graft ulcer.
yes, ma'am.
And you can have to give steroids in any systemic steroids in any keratoplasty, but it can be supported with systemic antifungals also, systemic and topical antifungal also. In spite of all this, the prognosis recurrence of ulcer is quite high in a therapeutic graft done for fungal ulcer, unlike a bacterial ulcer. Bacterial ulcer, if you are doing a lamellar keratoplasty and removing all the disease tissue, you are in a safer ground compared to fungal ulcer.
Yes, ma'am.
Anything else, if there is cornea is not that readily available for keratoplasty? What any other option, surgical options? The ulcer is progressing and threatening perforation.
If there is impending perforation, then we can use adhesive glues, and bandage contact lens can be applied to prevent the perforation.
Is bandage contact lens given in a corneal ulcer? The gloves are going to work in an ulcer with necrotic tissue?
No, ma'am. After removing the necrotic tissue, cyanoacrylate glue can be applied and then bandage, soft bandage contact lens. If the necrotic material is there, it will not.
This is not going to work in a fungal ulcer.
Madam is
So only
thinking of something more biological. That's it.
Something from the neighboring.
Amniotic membrane grafting.
What grafting?
Amniotic membrane grafting can be done, or
You are not clear.
conjunctival
What
flaps.
grafting?
Gunderson's conjunctival flap can be used to
Yes,
strengthen the
conjunctival
corneal
flap
tissue.
or even amniotic membrane is a better option than your tissue glue.
Yes, ma'am.
Suppose everything has gone well and it has healed. There's one area where all students go wrong. What are the different grades of corneal opacity?
Nebular opacity, nebular macular leukoma, adherent leukoma, and anterior staphyloma. This grading according to the structures involved. Bowman's epithelial layers healing will not produce any scar. The underlying structures like Bowman's membrane.
Leukoma.
Sorry, ma'am.
Leukoma.
Leukoma is deeper than 1/3 of the stroma is involved.
That is not the
The
answer.
scarring.
I was
If the
waiting.
underlying structures, if the underlying iris structures cannot be seen,
Yes,
that is leukomatous opacity.
that is the correct answer. It is not the level that is precise. It's a clinical examination. You are saying it's a leukomatous opacity or nebular opacity from the clinical examination. Any opacity which is as dense and white as the sclera and including all the structures behind it. That's the leukoma. What about the macula?
Macula iris details can be seen, but the pupillary areas obscured.
No. Leukoma nebula can occur anywhere in the cornea. It does not have to be over the pupil. It can occur in the periphery. Leukoma is a translucent opacity through which we can see the structures behind it. It is the level of density of the opacity that decides where it's a leukoma or macula, not its where it is situated. It can be
Less than 1/3 of the stroma is involved, and it is macular opacity.
What about the nebula?
Nebula anterior stroma, superficial stroma.
No, it can be anywhere in the stroma. These things you are following that what is that book? Your MBBS student's favorite book. What is that author's name? This is the mistake that everybody from MBBS level is following from that book. And that is pardon for a MBBS student, not for a PG student. These opacities can be at any level. Nebula can be at if there is a small Desmond break at the time of surgery or something happened and it heals, that will leave a faint opacity at the level of the Desmond's membrane. That is a nebula. Is it in the anterior stroma? It is not which layer of the stroma is involved. Is not. This is a clinical description. There is a leukoma or nebula or macula.
The amount of scarring ultimately, that is what matters. The amount of scarring. So
Yes, sir.
irrespective of the depth, no, the amount of scarring and the amount of opacification that has occurred.
Yes, sir.
And not the level or where the site.
Yes, sir.
And another important thing is if an ulcer is not responding to treatment, the other thing that you have to rule out is whether it is a non-infectious keratitis. That's an important thing. You may think that it is a corneal ulcer and you treat it, it is not responding. You have taken a scraping, repeated scrapings. Scrapings obviously will come negative. And the next thing that you see is whether it is an infectious or non-infectious. What are the common non-infectious keratitis?
Sterile keratitis, like because of diffuse epitheliopathy caused by the topical medications, which can result in toxic keratitis, and marginal keratitis.
After the treatment, we are seeking a case where it is infectious or non-infectious. How will you differentiate? And what are the causes for a non-infectious?
For infectious keratitis, the ulcer will be large and there will be associated circumciliary condition, and the corneal
Ulcers start as small because the size is not the criteria.
It will increase in size rapidly, rapid increase in size, and there will be associated more corneal edema.
And then I will ask another question. What are the conditions that produce a non-infectious keratitis? Types of non-infectious keratitis.
Marginal keratitis, then neurotropic keratitis, then toxic keratitis, and because of recurrent epithelial erosions in case of anterior basement membrane dystrophies.
Not answer. Have you heard of PUK?
Yes, ma'am. Marginal keratitis, peripheral ulcerative keratitis.
Which condition produces PUK?
PUK is associated with collagen vascular disorders, autoimmune disease, rheumatoid arthritis.
How will they present?
Peripheral ulcer, like ring-like ulcer, it will be associated with scleritis.
No, scleritis may not be there. What about a Moran's ulcer? How will it appear?
Serpiginous, it is like serpiginous fashion.
What is the identifying feature of a Moran's ulcer? You say it is a Moran's ulcer. Have you seen a Moran's ulcer?
It will be a central involving ulcer. It will come.
It is
will
not
be migrating from the periphery.
Ulcer. It is a peripheral ulcer which progressed along the limbus. It was healing at the tail and with an overhanging edge at the leading edge and healing and vascularization at the tail. It is not going to the central, it is going along the periphery. That is a typical Moran's ulcer.
Yes, ma'am.
Then what about staphylococcal marginal keratitis? How will you differentiate it?
Staphylococcal keratitis, which involve the center from periphery to center.
More 99% of the non-infectious keratitis are peripheral. The staphylococcal marginal keratitis, there is some staphylococcal infection, usually at the lashes. You may be having some blepharitis, conjunctivitis, then marginal infiltrates, multiple small marginal infiltrates around the limbus. Then what about shield ulcer? I am saying the common non-infectious keratitis. What is a shield ulcer?
Shield ulcer, same vernal keratoconjunctivitis. The lower portion of the ulcer will be the upper part of the pupillary area. Seen in VKC, keratoconjunctivitis.
Yes, where is it situated? Part of
the lower
cornea.
part of the ulcer is seen at the upper part of the pupil.
What part can be
Ulcer is seen at the upper half of the pupil.
In the area covered, but you leave the pupil. You not always reach the pupil.
Yes, ma'am.
It's a dense white plaque-like lesion in the upper part of the cornea, usually covered by the limb. Then what about the fraternal keratitis?
Sorry, ma'am.
Fraternal keratitis. I am giving you the different.
Fraternal keratitis, vesicular ulcer with a lesion of blood vessel.
In any peripheral ulcer where the vascularization is in excess of ulcer, two conditions you have to think of. One is a vesicular ulcer and the next one is more common than vesicular. Vesicular ulcer is very rare nowadays. These vesicular ulcers we used to see in our PG days when the tuberculosis was much more common in children. Now what we see in a small ulcer with a lesion of blood vessels, we have to suspect a retained foreign body. We have to scrape it and see whether it's a retained foreign body. That is one condition that produces so much vascularization in a small ulcer.
Yes, ma'am.
Then what else? Herpetic stromal keratitis, how will it appear? Another non-infectious keratitis.
In the Disciform keratitis and interstitial keratitis.
Keratitis, interstitial keratitis are all different things. This is stromal keratitis, is a necrotic stromal keratitis occurring in herpes. Disciform keratitis occurs in what type of herpes infection?
Non-necrotizing herpes simplex infection. Non-necrotizing stromal keratitis.
How does you differentiate a disciform keratitis from a corneal opacity? Patient can have a conjunctivitis and patient can have a corneal opacity. The conjunctiva will be red, there is an opacity in the cornea. How will you differentiate? You say this is not a corneal opacity, this is a disciform keratitis. How will you say? Disciform keratitis, you get a disc-like inside the cornea, isn't it? How will you differentiate these two? Since disciform keratitis is an active inflammatory condition, the surrounding cornea will show some edema. In a corneal opacity, the cornea will be perfectly clear surrounding the opacity. More importantly, there will be capes behind that lesion. We have to examine the cornea. If there are active capes, that means this is not an opacity, this is a disciform keratitis. Why all these things are important? Why it is important that you differentiate the infectious keratitis from a non-infectious keratitis?
To start the treatment, whether to start the treatment or
What treatment? All non-infectious keratitis need treatment with steroids, topical steroids. Only then they will respond. And if it is an infectious keratitis, then you are giving steroids straight away. That will worsen the condition. In a bacterial keratitis, you may manage with the additional broad spectrum antibacterial drugs, but in a fungal keratitis, you are giving steroids. That is going to be the end of that cornea. And if you are not giving steroids and you are giving the treatment for corneal ulcer, your lesion is not going to resolve. So whenever you see a non-healing ulcer, the thing that you have to look for is if there is any local precipitating
cause
factors.
of infection.
Yes, causative factors. Then is it really a infectious keratitis or a non-infectious keratitis? Then if you are convinced that it is an infectious keratitis, you have to do repeated testing to find out the causative organism. Whether the drugs you are putting is the right thing to combat that infection. The next
Yes,
thing
ma'am.
is whether the patient is putting the drops as per your advice. For that, if a patient is coming every day or on alternate day into the OP, you have ask him to bring the drugs also. How much he has used.
Yes, ma'am.
That's right. Anything more?
I think almost everything is covered, madam. Dimple, you had prepared well, presented well, answered rather well. Okay. Only thing I felt that you are a bit fast. So when you are very confident, no, you tend to become very fast. Your voice was clear, but if you make it a bit more slower, no, maybe that will gain you some 5 to 10% advantage in the marks. Okay, can be a bit more
Yes,
slower when you present as well as when you answer.
You have to
That is one
more
thing.
and louder, and also more on the clinical side.
Yes, ma'am.
Here the explanations are all more on the theoretical side. In a theory paper, you can write all these things, but when you are discussing a clinical headache, you have to be more on the practical side. You can see what is the things,
Ma'am.
then you can give all the additional things.
Yes, ma'am.
And the thing is, no, you had drawn in a reasonably good color-coded corneal diagram. So you said the depth of the depth of infiltration was up to the anterior stromal infiltration, something like that. So was that depicted in your drawing? You had one corneal drawing, no? Was the depth of corneal infiltrate depicted?
And
So is that
Yes,
important?
yes, sir. Slit views.
It was there. I think I missed that. It was there, no?
just
It was
there.
there.
Yes,
So
sir.
whenever you draw a corneal diagram, no, to show the depth of infiltration, so that I think I missed that. So, and so all PGs, the take home message would be, color coding. It's very important. So epithelial erosion, infiltrate, opacity, vascularization itself, superficial vascularization, deep vascularization, as you see in an IK, and even ghost vessels. So each thing is different. So even when we say vascularization, no, vascularization has got different components. So I think corneal drawings, it's very important nowadays when you present a corneal case. That is one thing. And another thing Madam was telling was the practice. I think still you said everybody sells Kimura spatula. I thought you also told Kimura spatula, no?
Yes.
When
Yes.
yes. So if you in an exam, no, probably you can say that to know to tell the examiner that you know things. Ideally, it is done with the Kimura spatula, but practically I did or we do in this way. Like maybe within we take with a how do you take it practically in your place? How do you take a corneal scraping in this
It's
glance?
band per 50 number blade or 26
Ah,
blades.
yes. So
needed.
yes. So whatever is so in an exam, even if you say that Kiburas, you say that ideally it is done, but practically we do in our institution in this way. So that is what you can say. So you should be practical in that. And another thing is it was also talked about when we talk about when we see inferior corneal ulcers. No, in any corneal ulcers, you should see all about the lid. Entropion, trichiasis, lag of thalamus, any foreign body, and I think you said syringing. No, syringing nowadays we seldom do. Doplas would be enough. If some examiner insists on that, probably we have that in back of your mind. And if you think that the examiner is thinking in terms of syringing, probably you can say that. But most of the situations practically we stop short with a aeroplast. But you can have the other thing in back of your mind. The examiner asks, "What did you do?" And so, and inferior exposure, especially, as Madam was telling, you look specifically for lid closure, lack of thalamus, and especially in old patients, long-standing diabetes, a bit of immunocompromised. You also see the other eye and see the inferior part of the other eye also. In some people, they will have a nocturnal exposure. So which may show signs of, so whenever you see inferior corneas in one eye, you see whether the other eye cornea in the inferior part, if you see any subtle lesions case, which may point to a nocturnal exposure, which the patient may not be aware of. So that is another thing you can you should practically look for in a case of especially inferior corneal ulcers. Okay.
Yes, sir.
And
So I think that's all.
one more thing I will like to add is this is a patient who has got poor vision in both eyes. Corneal ulcer, even if you successfully treat it, his vision is not going to improve.
Ma'am.
You have to focus more on his other eye. He has got cataract, he has got diabetic retinopathy. Even at this stage, you have to tell them that the prognosis for vision in this eye is poor. Even if the ulcer is healing, we have to focus on the other eye. You have to treat the diabetic retinopathy. A year and later, you may need a cataract surgery to retain some useful vision. And we have to,
Yes, sir.
whenever the patient comes with something that we cannot give back the vision, focus more on the other eye. Suppose a patient has come with a very advanced diabetic retinopathy, see the other eye. Whatever you can do, conserve the vision in the better eye. The better eye means, as far as the prognosis is concerned, the better eye should focus more on the better eye and also focus the patient's attention to retaining the vision in the better eye. So he was diagnosed
Yes,
with retinopathy, nothing has been done. Then as soon as the corneal ulcer is healed, we have to take care of the other eye and improve the vision in that other eye. That is also important. In any examination, that is the practical part. In any examination, when you are, how will you manage the case? You have to tell not only the management of the corneal ulcer, the other eye division, and retinopathy and cataract. You have to tell how will you manage the other eye also.
Yes, ma'am.
In other words, that is, you have to see the patient holistically, not only in this eye, this particular problem he has come forward. So, and expanding it further, no, if a patient has got severe a diabetic retinopathy, the patient hasn't met a nephrologist, you should tell him that also. So, you shouldn't be, and nowadays what happens is we are getting narrowly focused on a specialties and super specialties, that we don't think of the person holistically. So, that's also important.
Yes, sir.
Is anybody
APM KMO ഒക്കെ വന്നിട്ട് പോണ കണ്ടു.
I think there is a poor attendance from the PGs. They don't realize the importance of a corneal ulcer case. All students have seen in a corneal ulcer case. And if you are very unfortunate, you are going to get corneal ulcer case for your PG exam. One thing is this color coded diagram and everything they will forget to make, and the findings, clinical findings. Examiner is a very experienced person. Part clinical findings he can make out, you may miss so many things. Unlike a posterior segment finding or glaucoma case, corneal ulcer case is a very tricky thing. If you are very unfortunate, you get a corneal ulcer case for your PG exam. Okay.
എലിസബത്ത് ആണോ കൺക്ലൂഡ് ചെയ്യുന്നേ?
ഇല്ല സാർ, നമുക്ക് കൺക്ലൂഡ് ചെയ്യാം.
എലിസബത്ത് കൺക്ലൂഡ് ചെയ്യൂ.
ഇല്ല സാർ, കൺക്ലൂഡ് ചെയ്തു.
എലിസബത്ത് എല്ലാവർക്കും താങ്ക്സ് ഒക്കെ പറഞ്ഞ് കൺക്ലൂഡ് ചെയ്യൂ.
Okay, thanks to every participants. I expected more participants this week. I thought everybody will be interested in a common case, but very challenging case. But okay, I expect more participation from next case presentation onwards. Thanks to Girija Madam, Dimple, and thank you Hastasraman sir, and all those who participated.
Thank you, ma'am. Thank you, Girija ma'am. Thank you, Sahasranaman sir. Thank you, Elizabeth ma'am.
Okay, thank you.
So
Sir,
best of luck to all the PGs. Any PGs who is going to the exams in the recent future, and all others, best wishes.
The corneal ulcer is just like the simple muscle twitch in physiology. The simple muscle twitch you are getting, you are expected to fail. Just like corneal ulcer, you get your PG examination. It is very okay. Thank you.
Thank you, ma'am.
okay, thank you.